A very good evening, good afternoon, and good morning to everyone joining us from different parts of the world. On behalf of OPTOBHARAT, I, Shazia Shabbir, extend a very warm welcome to everyone attending today's international webinar on Sequential Management Protocol for Childhood Amblyopia. We are truly honored to have participants joining from India, the Middle East, UK, the USA, Africa, Russia, Singapore, Australia, and many other countries. Today's session promises to be a truly enlightening one as we explore scientific and practical approaches in managing childhood amblyopia. Joining us today to share his valuable insights on sequential management protocol for childhood amblyopia is our distinguished speaker for today's session, Dr. Saif Hassan Al-Rashid, Associate Professor of Optometry at College of Applied Medical Sciences, Qassim University, Saudi Arabia. Faculty of Optometry and Visual Sciences, Alneelain University, Khartoum, Sudan. Vice President, Sudanese Optometry Society. Dr. Alrasheed holds a PhD from the University of KwaZulu-Natal, South Africa in 2016, a master's degree from the University of Alneelain, Sudan 2008, and a B.Sc honors in optometry 2004. He has published around 80 research papers in reputed national and international journals and has participated in more than 10 scientific conferences globally. His key areas of expertise include childhood visual impairment, binocular vision, myopia control, and uncorrected refractive errors. We're deeply honored to have him with us today to share his valuable insights on this very important topic. But before we begin, there are a few quick reminders. Please make sure participants, your microphones are muted during the presentation. You may post your questions in the chat box and we'll address them during the Q&A session at the end. And stay with us till the end for announcements regarding participation certificates and OptoBharat membership opportunities. Now, without any further delay, let us welcome Dr. Saif Hassan Al-Rashid to begin his presentation on sequential management protocol for childhood amblyopia. Sir, the virtual floor is all yours.
Yes, thank you, organizer, for inviting me to introduce my presentation today. And thank you for all participants. I hope the sessions will be for you very useful to all. And thank you for organizer for inviting me to introduce this presentation. I will start my presentation now. If my sound is not that clear, please inform me. Now, my sound is clear for you?
Yes, sir, you're perfectly audible.
Okay, thank you. Now, the screen is in front of you.
Yes, sir.
Okay, okay. We start our presentations about sequential management protocol for childhood amblyopia. Yes, this my presentations outline. Yes, first we start by definitions of amblyopia, epidemiology of amblyopia, and we move to classifications of childhood amblyopia and etiology of childhood amblyopia. Then we go into briefly about investigations of childhood amblyopia, and finally we dive into sequential management protocol for childhood amblyopia. Yes, first we start by definitions. As you know, amblyopia is unilateral or bilateral conditions in which best corrected the VA is poorer than 6.6 in absence of any structural or pathological anomalies. But when of the but when or more of following conditions happen before the age of 6 years or happen during the sensitive period, if any problem happen during this period or before the age of 6 years, could lead to development of amblyopia. Yes, these conditions may be if anisometropia or an equal refractive error between the two eye happen before the age of 6 years. This could lead to development of amblyopia, and also if any type of strabismus is tropia, extropia, if this happen before the age of 6 years or happen during the sensitive period for development, this could lead to development of amblyopia. And also if there is a bilateral isometropy or bilateral uncorrected refractive error. And this commonly happen if the child have hyperopia. Yes, if the child have uncorrected hyperopia, and this uncorrected hyperopia in sensitive period, also this could lead to development of amblyopia, and also unilateral or bilateral astigmatism. If uncorrected astigmatism bilateral, just we continue on the presentations. As we mentioned before, if any of this problem is happening before the age of 6 years or during sensitive period, this could lead to development of amblyopia. And also, if there is any unilateral or bilateral astigmatism happening before the age of 6 years, also this lead to development of childhood amblyopia or any type of image degradations or any disorder covering the visual axis prevent development of retinal image could lead to development of amblyopia. Yes, the epidemiology of amblyopia, as you know, that the prevalence of amblyopia is slightly less, about 1.4 percent. This the prevalence of amblyopia in the populations, and the condition is a 4 times more common in premature children. The premature children have high risk for development of amblyopia, and also 6 more common among children with delayed development. And also amblyopia is the more common among smoking and use of drugs. If the pregnant woman use of alcohol or drugs, this lead to high risk for a child with amblyopia. Yes. Now we move to the classification of amblyopia. Yet, first type of amblyopia is the called stimulus deprivations amblyopia. This type of amblyopia is stimulus deprivations amblyopia happened if there is any disorder that covers the visual axis from development of image, such as, for example, such as the congenital cataract. If any congenital cataract happened during the sensitive period for development, this could lead to development of amblyopia. Or if there is any corneal obesity, also if there is any obesity in the cornea, this also could lead to development of amblyopia. And this type of amblyopia is the called stimulant deprivations amblyopia. Or if there is ptosis, congenital ptosis, if any type of ptosis this happen before the age of 6 years, this could lead to development of amblyopia. And this type of amblyopia is the called stimulus deprivations amblyopia. And anisotropic amblyopia, as you know, if there is any difference in refractive error between right and left eye, this lead to development of amblyopia. And this type of amblyopia is the called anisotropic amblyopia, or amblyopia due to anisometropia, or maybe amblyopia may be due to ametropic or uncorrected refractive error. If there is high uncorrected refractive error, particularly if there is high hyperopia, and this hyperopia happen during the sensitive period, this could lead to development of amblyopia. Yes, and also if there is high degree of astigmatism, unilateral or bilateral, this could lead to development of type of amblyopia. This amblyopia is the called meridional amblyopia, is due to uncorrected astigmatism. Yes, and this strabismic amblyopia is a very severe type of amblyopia and very difficult to treat. This type of amblyopia is commonly due to unilateral strabismus. Yes, if the strabismus is unilateral, maybe unilateral is exotropia or esotropia, but commonly, yes, strabismic amblyopia is the commonly happen in the child with esotropia. If there is any unilateral esotropia, this unilateral esotropia lead to development of strabismus, and this strabismus is called development of amblyopia, and this amblyopia is the called strabismic amblyopia. And commonly this happen in esotropic patients. If the strabismus is unilateral or is alternative, if the strabismus if the strabismus is alternative, this not lead to development of amblyopia. Just unilateral, strabismus lead to development of amblyopia. Yes, now we move to etiology of amblyopia. Yes, amblyopia is caused by inadequate stimulations of visual system. during the sensitive period of visual development or in early childhood or in less than 6 years. Yes, this is the main causes of amblyopia is inadequate stimulus, yes, of visual system. This inadequate stimulus of visual system. This happened during the sensitive period of visual development. If there is any inadequate or stimulation of the visual system during this period, lead to development of amblyopia. Yes, several authors reported that there is a change found in visual cortex area V1 and V2 with the loss of binocular driven. Yes, there is other theory for development of amblyopia. This theory is the called binocular competitions. Yes, this other theory for development of amblyopia, or this other theory for the causes of amblyopia is the called abnormal binocular, yes, competitions. Yes, there is this theory states that there is a competitive interactions exist between the two eye. There is a competitions between the two eye. There is a competition between sound eye and amblyopic eye during early visual development. One eye competitive advantage. One this eye competitive advantage is the sound eye or non-amblyopic eye result in dramatical change in visual pathway of disadvantaged eye or amblyopic eye. There is a competitions between amblyopic eye and normal eye. From these competitions, the sound eye or the normal eye get more got more advantage, and the amblyopic eye is a less advantage or become a disadvantaged eye. Yes, due to this or result of this, abnormal competitions, neurons in visual pathway of disadvantaged eye or amblyopic eye become or decrease in functions and number as a result of this abnormal competitions, and the pathway from advantaged eye, gradually, gun synapse. Yes, for that in early, if there is competitive and normal eye is a take advantage. The person commonly focus or use there is normal eye and ignore there is amblyopic eye. This also, some theory says that this lead to development of amblyopia. Yes, from these competitions, the amblyopic eye become have suppressions, or the brain suppress the image come from disadvantaged eye or from amblyopic eye. As a result, the normal eye take advantage to see, and the disadvantaged eye become amblyopic eye. This other theory for development of amblyopia. Also, there is very important to understand the critical and sensitive period if you need to treat and diagnose and to understand the prognosis of amblyopia. It's better, or it's good to understand the critical and sensitive period for development. Yes, the critical period for development is the short durations of time of maximum sensitivity. This a period from the pairs to from pairs to 3 years. This is a called critical period. If there is any disorder happen during this time or during this critical period, this will lead to develop amblyopia, and this type of amblyopia becomes severe amblyopia, and the treatment of this type of amblyopia becomes slightly more difficult if the amblyopia is happen during the critical period. Yes, the other period is the called sensitive period. Yes, this sensitive period is become from 3 years until the age of the 10 years. Yes, during the sensitive period, the visual system is at risk to change. If there is any amblyopia or any type of amblyopia happen during this year or during the sensitive period, become slightly less severe or less difficult in treatment than amblyopia that happen during the critical period. Yes, during the case history, or when you take in the case history for the type of amblyopia, it is better to ask when the time the amblyopia start. Yes, if this amblyopia is a start before the age of 3 years, yes, slightly you need to you need to focus on extensive treatment for this type of amblyopia, because any type of amblyopia happen during this period becomes slightly difficult in treatment. But if the amblyopia happen during the sensitive period, maybe slightly not severe type of amblyopia, and also the prognosis for this type of amblyopia is uh, good. Yes, and by critical period, yes, research predicts that human visual development continues through at least first decade. Yes, this some studies say that yes, the visual development is not just in sensitive period and critical period. And research predicts that yes, human visual development is a continuous through at least first decade, or maybe yes until yes the 10 years. Child have a 10 years still have some development of visual function for this child. For example, some authors say that dramatical response of adult with anisotropic amblyopia to treatment suggests that residual presbyopia remain in human visual just some studies say that some adult persons have anisotropic amblyopia. Thus, they respond well to treatment. Yes, this indicates that yes, this period or the period for visual development is continuous through at least first decade. But if any patients come in the clinic have a type of amblyopia, it is better to start treatment with him, not say you are beyond the treatment of amblyopia, you are not benefit from the treatment of amblyopia. This is specifically for the person with an asymmetropic amblyopia. Some studies say that may be response to treatment. Yes, now we move to investigations. Unfortunately, there is no reliable science to make patients, parents, or
يا
clinicians
ولد.
suspect the presence of amblyopia. Yes, this bad things, or this may be a bad phase of how to discover the child with amblyopia. Yet there is no reliable science for parent or clinicians to suspect the child have amblyopia. For that, most type of amblyopia is discovered during the vision screening. For that, the vision screening is a very important, yes, to discover amblyopia. Symptoms complaint of the player vision, headache, yes, ocular discomfort are potential symptoms that the patients with amblyopia may be reported, but also very likely there will be no symptoms, particularly in the patients with unilateral amblyopia. If there is unilateral amblyopia, the one eye is good and other eye have amblyopia, yes, the patients maybe have no symptoms. Yes, and the common finding during investigations of amblyopia, yes, refractive error, maybe hyperopia or maybe myopia or astigmatism. Yes, but commonly hyperopia lead to development of amblyopia, and stigmatism also lead to development of amblyopia. But myopic, currently, if you give the optimum corrections for the child with myopia, maybe the vision improved to 6.6. But commonly, yes, amblyopia happen in the child with hyperopia or astigmatism. Yes, also during the investigations, you need to assess the fixation characteristics. This is a very important. Yes, if you need to treat the cat with amblyopia, it is very important to assess the fixation characteristic for the patient. In almost all the cases of an isometropic amblyopia, the fixation is unsteady and central. Yes, and central. Yes, there is a unsteady amblyopia to assess the eccentric fixation, you see slightly out the center. This means that the fixation may be central, yes, central and unsteady. Sometimes maybe in central, and other time maybe yes outside from the central. This commonly in refractive amblyopia. This commonly happen in refractive or amblyopia, or in the child with an asymmetropic or isometropic amblyopia. But if you find any eccentric fixation, if there's find an eccentric fixation, that means the child may have strabismus, and this amblyopia may be yes due to strabismus. Yes, this eccentric fixation may be yes macular eccentric fixation or paramacular eccentric fixation, or maybe peripheral eccentric fixation. This according to yes a degree of strabismus with the child. If you found an eccentric fixation, that means this amblyopia commonly may be due to strabismus. Yes, if eccentric fixation is present during ophthalmoscopy in the eye, that is apparently without any ocular deficiency. If the child appears their eye is the good without any deficiency, this child may have micro yes microtropia. Commonly eccentric fixations happen yes, in the children with strabismus. It is very important to assess the fixation characteristic before to start the treatment. Yes, for example, if you found the central the fixation is a central, yes, the prognosis of the treatment of this child is good. But if you found the eccentric fixation is yes peripheral, or there is eccentric fixation, is slightly the prognosis for treatment of this case may be slightly poor. Yes, and also it's a very important things in amblyopia crowding phenomena. Yes, amblyopic patients have a better VA or visual acuity for single opto type than later place in row. Yes, yes. This is very important when you assess the VA of the child with the amblyopia. If you just use a single line, maybe the child reach 6'9". But if you use yes the raw VA, the VA just may be 6 over 18 or 6 over 12. This is a called crowding phenomena. But the crowding phenomena is commonly yes seen in the patients with strabismic amblyopia. Is commonly in the patient with strabismic amblyopia. Yes, strabismic amblyopia had significant difference in ability to correctly identify single letter versus crowded letter. Yes, the crowding phenomena is the useful method to differential diagnosis of refractive amblyopia. This give you indication this amblyopia is due to refractive or refractive amblyopia. Yes, after you collect all informations, after you get the patient history and get VA and use the visoscope and take all the examinations, you can reach to tentative diagnosis for this patient, or you predict the prognosis for this patient. Yes, for that the severity of amblyopia, is depend on the age of onset of refractive error or strabismus. Yes, for example, if the refractive error or strabismus is happening during the critical period, that give you indication this may be the treatment of this type of amblyopia is need slightly extend, yes, need yes slightly hard, or it's difficult for child to reach 6'6" easy, or the child maybe have poor prognosis if refractive error or yes strabismus happen during the critical period. But if this refractive error happen during 6 years of the age, this give you indication that this type of amblyopia maybe have a good prognosis. Yes, and also the amount of anisometropia. Yes, if there is a small anisometropia, or there is no difference between the refractive error of the two eye, maybe give you indications this type of amblyopia maybe yes maybe mild or moderate amblyopia. If there is high degree of anisometropia or high degree of strabismus, maybe severe type of amblyopia. Change yes during yes, the change is happening during sensitive period or critical period. Also, this is very important as we mentioned before. Yes, yes, a prognosis for refractive amblyopia is good. Yes, generally, if any amblyopia is due to refractive or due to anisometropia, the prognosis for this type is a good. Unfortunately, the prognosis for amblyopia due to strabismus slightly become poor. Yes, now we shift to treatment of amblyopia. Yes, according to as per and their colleague before 22, the initial or the primary treatment or primary therapy for unilateral amblyopia was to occlude the non-amblyoptic eye. This, yes, before, yes, 22. Yes, before 22, the initial therapy for amblyopia is to occlude the non-amblyoptic eye or to start patching. Yes, before to give the refractive, before to correct the refractive error, to start patching this treatment of amblyopia before 22. But now the treatment of amblyopia is slightly shift. Yes, for that there is some protocol now. There is the treatment of protocol is called management of amblyopia. Is need protocol to manage amblyopia, not just one step to give the child patching. That means you need to treat amblyopia. Now there is some protocol for management of amblyopia. Now we're going through to sequential or first. We need to understand the aim for sequential management protocol for amblyopia. First, the aim of all therapy protocol for amblyopia is to achieve functional binocular vision with equal VA. This is the primary functions for treatment of amblyopia. Yes, to give equal VA between amblyoptic eye and sound eye or normal eye, to give equal VA between the two eyes. This is the first aim for all therapy of amblyopia. Yes, the second aim, functional therapy result in equal VA in each eye with the comfortable binocular vision at all distance. Also, you need to achieve equal VA with the comfortable at the position at near and distant. And also there should be stereopsis. Yes, the big problem for strabismic patient is stereopsis. Also, you need after, for example, if you trace the patient and there is vision is reached to 6.6, you need also to develop the stereopsis for these patients. There is some study found that after treatment of amblyopia, after treatment of amblyopia child, if their vision reach 6.6, he become have a problem in yes, stereopsis. Also, you need to develop the stereopsis for this child, and also you need to develop yes a normal range of motor fusions. You need to develop the motor fusions, or need to develop convergence and divergence for this patient, or you need to develop yes a positive fusional reserve and negative fusional reserve for this patient. For that, the treatment of amblyopia now become the management, not just single, just to give the patient patching and say this is the treatment of amblyopia. And also the management recommended for amblyopia is sequential protocol. Yes, sequential program or sequential protocol. Yes, step by step protocol that consists of the four step. Now we're going to see this step for sequential management of amblyopia. Yes, the first step for sequential management protocol for amblyopia, the first step is the full refractive correction. Yes, this is the first step to treat amblyopia, to give the child full refractive correction. This is the first step to treat amblyopia, to give the child yes full refractive corrections. Yes, and wait for refractive adaptation, not just to give full corrections and to say the child go and use this glasses. No, just to wait for refractive adaptation. There is a time for refractive adaptations. Yes, to wait about BIDIC. Yes, the BIDIC recommended that after giving the child for refractive correction, wait yes for 18 to 22 weeks just for refractive adaptation. Yes, the BIDIC says that optical correction alone, yes, treat about 35% of the child with anisotropic amblyopia. Child with anisotropic amblyopia is if you give him full refractive corrections and wait for the optical adaptation, 35% of this case just with optical corrections alone is treated. Not need to go to second step for the correction. Just after wearing the full refractive arrow and wait for optical adaptations, they achieve good VA. And also, BIDIC says that strabismic and compound strabismic anisometropia about 25% of the cases just with refractive alone just reach to maximum VA, not need to move to second step. For that, correction of refractive error is a very important step in treatment of childhood amblyopia and wait for refractive adaptation. Yes, these refractive adaptations need, yes, some time. Yes, the second step in sequential management protocol for implement to improve the alignment if there is visual axis when needed. Yes, to improve if there is high degree of phoria or if there is any microtropia, if there is high degree of exophoria, you need, if there is a latent strabismus, you need to correct this problem as a second step. Yes. After first step, you give the child for refractive correction and wait for adaptation period. This period extend from 18 to 22 week. After that, to start the next step in this therapy, just if there is any alignment to improve this alignment. Yes, for example, yes, add plus lenses. If you find the child with high AC over A ratio, if you find high AC over A ratio, high AC over A ratio, that means if there is one diopter, yes, yes, produce more than six accommodative convergence. This means that this the child have a high AC over A ratio. You need to give him or to add plus in their prescriptions. If there is half prescription, you need to give him maybe over plus corrections. And also, if there is insufficient stigma, yes, insufficient accommodations. If there is insufficient accommodation, if you measure ambulatory accommodations and you found the ambulatory accommodations of this child is less than 8 matching, yes, that means that this child maybe have insufficient accommodation. Also, you need to add plus for this child. This in yes, in a second step or in second step in sequential management protocol for amblyopia. Yes, at prism, if there is a isophoria, if there is a distant isophoria, add base out prism for the child. And if there is hyperphoria, add base down prism. But if there is any degree of exophoria, it is better to give the child exercise. This in this protocol not recommend to give the child over minus corrections. The over minus corrections maybe lead to development of myopia or maybe lead to high degree of myopia. For that, this protocol, yes, and not yes. Not recommend in the child with the high degree of exophoria to give him minus correction. It is better to give him exercise. Better to give him exercise, and exercise that improve positive regional divergence may be very good for the child with high degree of exophoria. Yes, in third step, yes, patching. Yes, look for, yes, here, as you mentioned before 22, the first is, yes, the first, yes, step in treatment of amblyopia patching. Now, in sequential yes, management protocol for amblyopia, the patching is the move to third step. In the third step, you will try to use patching or try to use, yes, occlusion for the child. Yes, patching is of the healthy eye is the standard treatment of unilateral amblyopia since 1743. Yes, from the past, yes, the patching is the standard method for treatment of amblyopia. Yes, when the VA does not show improvement with the optical corrections and remain the difference of yes, zero point 0.2 log mark or greater between the two eyes, the occlusion therapy, yes, is started. Yes, when you give the child for refractive corrections and you give him, for example, adding, if this a child have a high AC over A ratio and wait him and there is no improvement of VA. Now the time for start the patching or the time for start the occlusion therapy. Yes, direct occlusion. Yes, this protocol recommend to use a direct occlusion. Yes, a part-time occlusion from 2 to 6 hours. Just to use part-time from 2 to 6 hours. Not this protocol not recommend to use full-time occlusion or 12-hour occlusion. Just this protocol recommend to use part-time to hour to 6 hour occlusion or atropine penalizations. It is a very yes. Also, atropine penalization one drop yes, in sound eye at the weekend. Just if the child, maybe if the child not compliance with direct occlusion, you can recommend him, yes, atropine penalization, just only one drop at the this yes this atropine penalization work as occlusion therapy. Yes, according to BDIC finding, yes, BDIC, yes, this group focusing on pediatric eye disease, on amblyopia, and common disease for children. According to their finding, patients younger than 4 years tend to respond better than those older than 6 years. The treatment of amblyopia in this before 4 years, this is a child in the critical period. If you start the treatment and if you start patching in the critical period, there is there is a good response to the therapy. But if you start, yes, the patching after the age of 6 years, there is a response, but not um, uh, achieved as compared to age of 4 years. Yes, when starting treat the patients with occlusion, the majority of improvement happen during the first week. Also, this is very important. Yes, majority of improvement of the VA of the child is happening during the first week. Yes, some studies say that it is better to increase the dose of occlusion during the first week, because most of improvement of the VA happening during the first week. It is very important to, yes, to increase the dose of occlusion during the first week. Yes, yes, here some study to evaluate the effect of occlusion therapy according to their dose. For example, here the study studies the effect of occlusion, or compare occlusion therapy against atropine therapy in the child their age from 6 to 7 years. They find similar improvement. Yes, for that say it is better to use occlusion than atropine. Both give the same outcome. It is better to use occlusion is safer than atropine. As you know, atropine have some side effect, as you know. But if the child not complying with the occlusion, it is better to use for him atropine. And also, this the BDIC evaluate also the full-time occlusion against the 6-hour patching. Also, they find similar improvement when we use 6-hour patching full-time, like a 12-hour patching, or if you use 6-hour patching, have a similar improvement. For that, it is better to use 6-hour patching. And also in other study, they use a 2-hour patching against 6-hour patching. Also, they find, yes, similar improvement. For that, this protocol recommend it use start, yes, occlusion therapy 2 hours. Just start by 2 hours. Is 2 hours give the same, yes, improvement as the 6 hour? It is better to start by the 2 hours. Yes, for that, for moderate amblyopia, VA, if the BA better than 6/24, it is better to start by the 2 hours occlusion per, yes, start
Yes,
by,
start by
sorry, just start by 2 hours per day. And if the child have a severe type of amblyopia, if the amblyopia is severe, if this amblyopia is severe, yes, the VA is the worse than 6/24. It is better to start by 6 hour per days. Yes, here the BDIC, or here this protocol, they divide it. If the child have a moderate amblyopia, the VA is better than 6/24. It is better just to start by 2 hour per day. And if the child have a severe amblyopia, it is better to use 6 hour per days. Yes, if the VA is improved at least one line, the occlusion dose can be remain the same as starting dose. For example, if you prescribe 2 hours, yes, yes, after 1 month, you see the improvement, one line. Yes, the child from 6/18 improved to 6/12. There is improvement of one line. It is better to recommend the child to continue with the same dose of occlusion as the 2 hours if there is improvement of one line. But if the improvement of VA less than one line, if the VA is less than one line, if in the first time if you prescribe 2 hours, you find there is no improvement in the VA, it is better to double the time for occlusion from 2 hours and increase the time to 4 hours per days. Yes, step four for sequential management protocol for amblyopia. Yes, monocular, maximize monocular acuity. Yes, you need to improve to maximize the monocular acuity. This is by vision therapy training and binocular improvement, or to improve the binocular functions, like use of dioptic therapy. Yes, this exercise or therapy is called dioptic therapy, lead to significant improvement in VA and also lead to improvement of stereo acuity for the children. For that, in this protocol says the end point for treatment for amblyopia, it is better to use the dioptic therapy. This dioptic therapy lead to improvement the stereo acuity, and also if there is any this lead to treatment of suppression, or this is called anti-suppression therapy. The child use red-green glasses and read in the chart like this. This, yes, the red in front of amblyopic eye. Yes, this lead to eliminate if there is any suppression, lead to eliminate suppressions and also improve the stereo acuity for the child. Yes. Now we go to for recap, or just we're going to summarize what we mentioned in this protocol. Yes, or we see the systematic methods for management of childhood amblyopia. Yes, first, as we mentioned, start with the full cycle corrections, give the child full cycle corrections and wait for period. This we call optical adaptations. This optical adaptation from 4 to 5 months. After, give the child full correction, wait for 4 to 5 months. And at this time, you need to see the child, or to follow up the child every 6 to 8 weeks to see if there is any improvement uh, happen. Yes, for example, if the VA is improved, if the VA, if the visual acuity is improved just by the optical corrections, yes, just continue, just let the child to continue with the correction. Yes, if the VA is not improved, yes, if you give the child full corrections and give him this adaptation period and there is no improvement in the VA, now you need to start the next step, or the second step, as we mentioned, in sequential yes, in sequential management protocol, add lenses. Yes, as you mentioned, add lenses at the plus lenses if there is high AC over A ratio, or if there is or if there is insufficient accommodations, you can add the plus lens over the prescribed over the prescription for this child, or if there is high degree of Athophoria, you give him prism. Of there is high degree of exophoria, it is better to give him exercise. This protocol not recommend to give him over minus correction. Yes, if the VA is improved, yes, let the child to continue with the corrections. If the VA is not improved, now you need to move to second step. Give the child patching, or give the child occlusion therapy. Start by 2 hours every day, 2 hours every day. Or if the child not compliant with occlusion therapy, give him atropine at weekend. Yes, if the VA is improved, yes, give the child give the child the binocular therapy, as you mentioned, it is better to give him the coptic therapy, yes, to improve the stress you need to prevent the time 6 hour, yes. If the VA improve after increase the time for occlusion, yes, also move to binocular therapy or perceptual training. Perceptual training such as the cam vision stimulator and also dioptic therapy is the one of perceptual training. Also, some study found, yes, the optic therapy and perceptual training such as the cam vision stimulator could lead to improvement of severe type of amblyopia. If the VA, if yes, improve, yes, stop the therapy. If the VA is not improved, try to use drugs. Now there is a new drugs is called, yes, levodopa, carbidopa. This drug have effect on neuro on the brain plasticity. This drugs in some study use these drugs with the occlusion. They say they improve this lead to significant improvement of amblyopia, or maybe the child have some abnormality need yes surgical treatment. Yes, this systematic method you can follow this systematic method for management of the child with amblyopia. Yes, in conclusion, yes, significant evidence proves that childhood amblyopia is treated through a systemic methods, starting from correcting refractive error, yes, with the period of the optical adaptations, followed by patching therapy or atropine penalization. New methods to improve binocular functions and medications. There is new medication, as we mentioned, the carbidopa, levodopa, lead to facilitated visual neuroplasticity, have been found to be useful in treatment of amblyopia that not responds to conventional treatment. The conventional treatment as the correction of refractive error um, and occlusion therapy. Yes, this my reference, and thank you.
Thank you so much, sir, for such an amazing session. Now we'll be taking questions. So if you all have any doubts, please feel free to drop your doubts in the chat box and I'll read it out aloud. Attendees, if you all have any doubts, please feel free to ask your question in the chat box and I'll read it out aloud for sir to respond to.
والله ما عرفت أول بلوتوث هم ترقصوا البلوتوث.
If you all have any question regarding amblyopia or its management or regarding this session, then now is the time. Drop your question in the chat box.
مش ما في
Okay,
حاجة
sir,
أصبر.
I think we have a question now. In childhood amblyopia, whether a child can recover completely or not? Sir, am I audible?
Okay, I reply to this question or wait for?
Yes, sir, please reply to this question.
Yeah, the treatment, as we mentioned, the treatment of amblyopia maybe depend on the type of amblyopia. For example, if this amblyopia is due to, yes, uncorrected refractive or this amblyopia maybe, or this amblyopia is due to anisometropia, and this amblyopia is happening in sensitive period, this child may be fully recovered from amblyopia after follow the treatment protocol for amblyopia. But for example, if this amblyopia is due to strabismus or strabismic amblyopia, and this amblyopia happened during the critical period, This commonly lead to severe type of amblyopia. It is a difficult to fully recover from this type of amblyopia. But if you use all the management protocol, you can achieve, yes, optimum correction for this child. Yes, for that I say the treatment of amblyopia depend on type of amblyopia and severity of amblyopia and when this amblyopia is happening.
Very well explained. If there are any more questions. Okay, so we have another question. The question is, when do we use prism and be benefited by it?
Sorry, what?
The question is, when do we use prism and be benefited by it?
Okay. Yes. Commonly we use a prism, for example, after we given the child full correction. For example, if you find after optical adaptation, for example, if you find this a child have a high degree of esophoria, for example, high degree of esophoria. Yes. Commonly, yes, esophoria response will to plus correction or maybe responsible to prism correction. This commonly if the isotropia sorry, if isophoria as a distant, it is better to give the child prism. Yes, but you need to give just a small prism, not high degree of prism, just a small prism, and you to split the prism between the two eye. And also if there is any vertical foria, and also it is a better vertical foria is not it cannot be treated by glassy minus lenses or plus lenses or even exercise. Yes, if there is any vertical foria, it is better to give the child a vertical prism. And this, yes, the use of prism, as you know, is very rare, but in some specific conditions, we can use the prism for the children, specifically if the child have iso phoria, and this is a phoria at distant. Any distant is phoria, it is better to correct it by the prism. If there is near iso phoria, it is better to give him plus corrections, maybe commonly near is the foreign is associated with high AC over A ratio. As we mentioned, if there is high AC over A ratio, it is better to give the child plus to add plus corrections. If there is any is the foreign at distant or any vertical foria, it is better to give the child prism.
Very well explained, sir. We have another question. The vision in right eye is 6'9", and that in left eye is 6'6". In the patient aged 16 years due to congenital ptosis, the patient got operated for the same at 5 years of age but still has intermittent ptosis. ASD with ID. Can we suggest him vision therapy for this, or I can work on his saccades, pursuit, and visual perceptual skills?
I think this maybe this have as you mentioned deprivations amblyopia. This amblyopia may be due to ptosis. Prism is recommended if there is any deviations. If there is any deviations, so you can prescribe. If there is microtropia or if there is any deviations, you can't prescribe prism. But if this, as you mentioned, may be mild amblyopia, and this may be due to ptosis or called stimulus deprivations. Amblyopia, this child maybe need surgery, or as mentioned, surgery for ptosis. Sometimes ptosis maybe need more than one surgery, but this child is better just to give him after treatment of ptosis. It is better just to give him full refractive correction and wait and give him optical adaptation period and wait to see if there is response.
Okay, sir. We have another question now. In common, at what age range have you seen the best visual improvement with amblyopia therapy? And do you still recommend treatment beyond the critical period?
Um, Yes, as mentioned, if you start treatment of amblyopia at the critical period or from 1 year to 3 years, there is maybe very nice or very good response or very good prognosis for the child to recover from amblyopia. But if you start treatment of amblyopia in late, it is maybe not maybe not fully the patient maybe not fully recovered. But some, as I mentioned in the presentation, yes, some studies say that some adult with anisometropic, this anisometropic, just focusing on anisometropic amblyopia, it give him optical corrections and wait for optical adaptation period. After that, we give him occlusion therapy. Some patients may response to this treatment. For that, say it is better not if any patient come to you in the clinic, if adult, no say, yeah, no, no, the time is over, you are not responsive to treatment, try give him, first try give him full optical corrections, give him optical adaptation fluid. After that, give him occlusion therapy. As mentioned, now there is some medical treatment. That medical treatment, there is some tablet is called levodopa carbodopia. This drugs is prescribed along with occlusion therapy, and this commonly used in adult patients. That drugs is lead to develop some neuroplasticity or lead to develop the brain plasticity, lead to develop brain plasticity, maybe lead to development of amblyopia. This protocol say any patients, if adult patients have anisometropia, but if, for example, if adult patients have amblyopia and this amblyopia is due to strabismus, it's difficult. The treatment of any strabismic amblyopia is very difficult. But if this strabismus is anisometropia, try with him, give him full optical correction, give him all, as we mentioned in this protocol, try with him. If there is an improvement, that is good.
Okay, sir. Now we have another question. How do we determine the amount of prism to be prescribed?
Yes. Yes, this is yes, this is a nice questions. Commonly, if you need to determine the prism, just you say it is to prescribe a small amount of prism. That small amount of prism, commonly prism is prescribed according to shared criteria. Yes, shared criteria says that it is better to prescribe the fusional reserve opposite to deviation. For example, if child have a prism, yes, isopropia, sorry, isophoria, a prism isophoria, and have an fusional the deviation. For example, if you make the fusional version is 10 and you need to decrease the 2i. Yes, now you decrease the ISO from 8 to 6 and increase the visional version. If have a visional version before 6, you increase or if you have a present version 10, a negative visional version 10, you increase the visional version from 10 to 12. Yes, charity says that you need to just to prescribe a small amount um, of of prism. That prism lead to reduce the deviations and increase the opposite regional variant, and that the opposite regional variance should be double the deviations. For that, for this criteria, it is better to prescribe the prism. commonly just to prescribe small prism. Not, for example, if you measure the prism, 8 prism to give a prism. No, no, no. Just as you mentioned, you use shared criteria. To according to shared criteria, you need to prescribe the prism for the patient.
Okay, sir. I think we do not have any more questions now. So, thank you so much, sir, for sharing your time, expertise, and experience with us. A special thanks to all our participants from across the globe for joining today's webinar. Certificates will be sent to all registered participants who have filled out the certificate request form. On behalf of OptoBharat, this is Shazia Shabbir, your moderator for today's session, signing off with warm regards. Have a great day ahead.